Page number 230. Histopathologic features and theories of mechanism. The central cornea is typically normal, but the peripheral cornea has the characteristic prominent anteriorly displaced Shalbe line. The latter structure is composed of dense collagen and ground substance covered by a monolayer of spindle-shaped cells with a basement membrane. The peripheral iris is attached in some areas to the corneoscleral junction by tissue strands, which usually connect with the prominent Shalbe line. Occasionally, however, the adhesions insert anteriorly or posteriorly to the Shalbe line or on both the sides of the ridge. The strands consist of iris stroma, a membrane composed of a monolayer of spindle-shaped cells, or a basement membrane-like layer, or both. A membrane similar to that associated with iridocorneal tissue strands has been observed on the iris, usually on the portion toward which the pupil is distorted. In the quadrants away from the direction of pupillary displacement, the stroma of the iris is often thin or absent, exposing pigment epithelium which may also contain holes. The iris, peripheral to the iridocorneal adhesions, inserts into the posterior aspect of the trabecular meshwork. The meshwork may be composed of a scant number of attenuated lamellae which extend from beneath peripheral iris to the prominent Shalbe line and are often compressed, especially in the outer layers. Transmission electron microscopic study suggests that the apparent compression may be caused by incomplete development of the trabecular meshwork. The Schlemm canal is rudimentary or absent. Page number 230, figure number 14.11, light microscopic view of an eye with Axenfeld Reiger syndrome shows a prominent Shalbe line composed of dense collagen and ground substance covered by a monolayer of spindle-shaped cells with a basement membrane. A. Anterior insertion of the iris is present. This may be seen in several forms of developmental glaucoma. Figure number B. An iridocorneal adhesion arrow extending from the peripheral iris to the prominent Shalbe line. On the basis of clinical and histopathologic observations and the current concepts of normal anterior segment development, a developmental arrest occurring late in gestation of certain anterior segment structures derived from neural crest cells has been postulated as the mechanism of Axenfeld Reiger syndrome. This leads to the abnormal retention of primordial endothelial layer on portions of the iris and anterior chamber angle and alterations in the aqueous outflow structures. The retained endothelium with associated basement membrane is believed to create the iridocorneal strands, whereas contraction of the tissue layer on the iris leads to the iris changes, which sometimes continue to progress after birth. The developmental arrest also accounts for the high insertion of anterior uvea into the posterior trabecular meshwork, similar to the alterations seen in congenital glaucoma. This results in the incomplete maturation of the trabecular meshwork and Schlemm's canal, and these defects are thought to be responsible for the associated glaucoma. The neural crest cells also give rise to most of the mesenchyme related to the forebrain and pituitary gland, bones and cartilages of the upper face, and dental papillae. This may explain the developmental anomalies involving the pituitary gland, the facial bones, and the teeth. Neural crest cells also contribute to many other structures, including the walls of the aortic arches, genitalia, spinal ganglia, long bones, and melanocytes, which appears to explain the wide range of systemic anomalies that may be seen in some patients with the Axenfeld Reiger syndrome. Chapter number 14, Childhood Glaucomas Clinical Presentation. Page number 231, figure number 14.12, Theory of the mechanism for ocular abnormalities of Axenfeld Reiger syndrome. Insets show cross-sectional views of anterior chamber angle corresponding to area within the rectangle. Figure number A. Partial retention of the primordial endothelium E on the iris I and anterior chamber angle ACA. Incomplete posterior recession of peripheral uvea from trabecular meshwork TM, and abnormal differentiation between corneal and chamber angle endothelium with a prominent anteriorly displaced Schwalbe line. SL. Figure B. Development of tissue strands from retained endothelium crossing the anterior chamber angle. Figure C. Contraction of retained endothelium with iris changes of correctopia C, ectropion uvea EU, and iris atrophy IA, which may continue after birth. A tissue strand TS can also be seen. Figure D. Incomplete development of trabecular meshwork and Schlemm canal SC. Continued traction on the iris with possible secondary ischemia leads to hole formation H. Genetic linkage. The Axenfeld Reiger syndrome is thought to have a genetic basis with an autosomal dominant pattern of inheritance. Tremendous advances have been made in the understanding of the molecular genetics of Axenfeld Reiger malformations. 3 chromosomal loci have been demonstrated to link to the Axenfeld Reiger syndrome and related phenotypes. These loci are on chromosome 4, 6, and 13, chromosome 4q25, 6p25, and 13q14. The genes at chromosome 4q25 and CP25 have been identified as PTX2 and FOXC7 respectively. Mutation in these genes can cause a wide variety of phenotypes that share features with Axenfeld Reiger syndrome, Axenfeld anomaly, Reiger syndrome, iridogoniodysogenesis anomaly, iridogoniodysogenesis syndrome, iris hypoplasia, and familial glaucoma iridogoniodysplasia. These conditions all have sufficient genotypic and phenotypic overlap to be considered one disorder. Genetically, the Axenfeld Reiger syndromes can be considered in 3 types. Axenfeld Reiger syndrome type 1 is caused by mutation in a homeobox transcription factor gene PTX2 in bracket OMIM 601542 bracket complete. Linkage studies indicate that a second type of Axenfeld Reiger syndrome maps to chromosome 13q14, that is RIG2, in bracket RIEG2, OMIM 601499 bracket complete. A third form of Axenfeld Reiger syndrome, that is RIG3, in bracket RIEG3, OMIM602482 is caused by mutation in the FOXC1 gene. In bracket, OMIM601090 bracket complete on chromosome 6p25. In a clinical series of patients with Axenfeld Reiger syndrome and mutations in the PTX2 or FOXC1 genes, 75% of the patients had glaucoma that developed in adolescence or early adulthood, and patients with PTX2 defects or FOXC1 duplications had a more severe prognosis for glaucoma development than patients with FOXC1 mutations did. This complex genetic disorder has overlap with other anterior segment dysgenesis, and future studies may someday help predict how phenotype-genotype classification may assist in genetic counseling as well as prognosis for glaucoma treatment and vision preservation in affected individuals.